Matthew Holt off the Hems floor with an old friend who is doing something new, or actually not that new, but it's new to the world, I think. It's Chuck Saunders, the CEO of Integra Connect. Prior at Healthogen back in Aetna days, and before that, way back when at EDS and elsewhere. I can't think of the long history of stuff, Chuck, but enough that you've been doing. So the new venture, you announced just this week, and but you've been doing stuff for a little over a year. So tell us what it is.
The company has been in stealth mode for about a year and a half, but we did make an announcement this week about our coming out party. Integra Connect is a company, and what we do is provide a cloud-based business and technology solution for value-based specialty care. So it's a comprehensive end-to-end solution that enables specialists to manage populations and to flourish under the new post-MACRA alternative payment models, the oncology care model, and others, bundled payments and so forth. Now, I think you're very familiar with the phenomenon of ACOs and patient-centered medical homes, and I think that those models work well for two ends of the spectrum. One, people who orbit an institution, and those who are primary care oriented. But there's a vast swath of the population in the middle that have a chronic disease, and they really see their specialist as their primary care physician. And for them, there really is no good value-based care solution. And what's come recently with the oncology care model and CMS is something that the specialists are completely unprepared for. They don't have the infrastructure, the tools, or the capabilities. So we provide an end-to-end cloud-based solution for that with a number of different components, specialty-specific EHR, specialty-specific revenue cycle management technology for managing risk and alternative payment models, an entire population health platform with care management, advanced analytics for risk stratification, regulatory reporting for all of the quality measures and others that are required by CMS, and then patient engagement tools. Behind that, we back that up with services, so revenue cycle management is one, care management and call center and nurse navigation services are one. We're aimed primarily at the big specialties like oncology and all of those that use a high-cost specialty drug that creates a large cost issue for healthcare. And our customers are primarily providers, and we're aligned with providers in these solutions. And then secondarily, whoever bears the risk.
So talk about that risk-bearing part. We've had this conversation God knows how many times over the years, but it started to come much more quickly over the last 2 to 3 years than it had been for many years. On the other hand, we have a new administration in power, which the new Secretary of HHS has said some rather dubious things about bundle payments and risk sharing. Obviously, MACRA did pass pretty easily. That's your bet, though. You're betting that we're going to continue in that path we've already been for the value-based care?
Well, I don't know that the country has much of a choice. That the healthcare costs are unsustainable, and I think industry-wide the concept of value has been embraced, and most recently by CMS and the MACRA legislation, which, as you know, had broad bilateral or bipartisan support. And in rolling that back, I don't really see that as an effective solution because healthcare costs would only go up, and we'd be paying again for units of service, and which would drive volume, and that's not the solution for healthcare. So I don't suspect that that's going to change much. I think that the future is still about value-based care. Even before CMS was in the game, the commercial payers were doing it.
Right, you were doing it, right?
Exactly. I was in it back in the 90s, in the capitation days in California. And concepts of HMO and so forth are not leaving the market.
Okay, so we assume that the business and the market's going the right direction. A lot of people are coming at health, this value-based care from different angles. You mentioned medical homes, you mentioned the big ACO systems. Presumably they think they're doing this already, so why do you think there was a gap?
Well, you take a look at most large health systems that have embraced the ACO model. A lot of the specialists really are not employed by those health systems.
Right.
They're generally community-based, and they have many places that they could admit. In fact, many specialties like urology have vertically integrated, so they have their own ambulatory surgery centers, their own imaging centers and cyber knives and pharmacies and so forth. So they're really left out of the ACO formula. So this really provides a full stack of capabilities so that they can actually manage populations. And in fact, they can even be proactive with payers to create alternative payment models around their own networks for managing populations on a carve-out basis.
All right, so you're seeing them as being able to go to payers and start taking on bigger risk, and I assume pushing this across multiple groups as well back in and seeing those kinds of alliances emerge amongst those bigger specialty groups?
Yeah, I think that there'll be things like narrow networks that are built around single specialty populations, and then large MSOs that are multi-specialty, but the populations are intensely managed around evidence-based care paths and aligned financial reimbursement. So, and I think that a lot of employers and payers would love to have a solution that not only flattens trend for difficult populations, but actually even decreases it, particularly where specialty pharmaceutical agents are involved, because those are such a rapidly rising cost for healthcare, and there's not a good solution for it unless you bring it into the value-based formula.
Well, you may have some opposition from certain specialty-based pharmaceutical manufacturers, but that's a separate point. So tell me a bit about the company. You're just out of stealth. You've been around 15 months. Give me a sense of how many people and a bit about how it got funded.
So the company is self-funded. The company is built on a number of individuals that have been serial entrepreneurs and created a number of large companies. Raj Mantina, the founder, was also the founder of ION and P4. I myself have headed up Healthogen, and before that Broadlane, and part of WebMD and all of that. So we've been around for a while, and self-funded company, and we're just over 1,000 employees, and we've got 7 customers, and we're managing a couple billion in revenue spend right now. So we've moved very, very quickly in about the last 12 months. Put together.
I wonder why I haven't seen you. I've seen your daughter a bit, but I haven't seen you for a year or so. That's where you've been. That's great. And then tell me the last part. Obviously, as this world opens up and we go to it, the big players on the floor out there, the Epics, the Cerners, they're starting to, Cerner starting to move into population health and starting to look at these other areas because their kind of core business is flattening a bit after meaningful use is done. Where do you see the relationship between an organization like yours and those sort of large EMRs? Are you the next generation of plays, or might you end up doing some kind of alliance with an Athena or some other play like that?
Well, I think just like Health 2.0, we're Population Health 2.0.
Right.
Because it actually embraces, it's a solution that embraces some of the most intractable problems in healthcare, and it's not just a broad solution that is partially effective. I think if you know that with the ACOs, about a third of them that actually create savings, about 2/3 of them don't. But this is a rifle shot into populations that actually are very, very costly and difficult to manage. And unlike a lot of companies you'll see on the floor at HIMSS that have found a way to put population health in their banner, population health is really more than some point solution about analytics. It's more than than putting a front end forms on your EHR so that you can do a care plan. It actually involves the actual process of care management to manage people across the continuum, with the goal of reducing unnecessary hospitalizations, ER visits, and use of resources and so forth. And that requires a combination of both processes and technology in a very comprehensive way. I spent the last 5 years at Healthogen developing some beautiful tools and technologies, but the industry has been very fragmented about knitting all those tools and technologies together, with EHRs that don't perfectly exchange CCDAs, and data that's not liquid, and workflows that don't integrate seamlessly between the point of care and the care management activities. And what we're trying to do is solve for that with complete and seamless integration of both workflows and data across the continuum. Now, we do integrate agnostically with any source data system. So, for example, if somebody is in love with their EHR, for example, Epic, we'll just simply integrate to Epic so that we actually can integrate those CCDs. We have many customers, in fact, that are on a variety of different EHR platforms, but we can still implement and manage the oncology care model across a heterogeneous technology landscape.
It's a complex world, but one in which you can take data from multiple sources. Maybe somewhat painful. It's been over time, and I'm sure you'll be working on that as you go. But certainly, it's an interesting way that we're seeing the change in how people are approaching thinking about how do you manage high-cost patients, which were kind of always assumed that would be handled somehow externally there, and now you're actually providing a resource. But I think what you said about adding services and adding an integrated system across all these different pieces to that is going to be very important, because where we've seen it fail before is people be giving out technology that hasn't got properly used. So if you can combine it with services and an approach that puts it in place, I think you're in a great shape.
Yeah, there are a lot of technologies out there that effectively solve a particular point solution, and but in the hands of providers who've actually never done it before, who's never actually managed a population, and don't know how to put it to use. It's like giving a complicated tool for carpentry to somebody that doesn't actually know how to build something. And so there needs to be a cultural change with physicians. There needs to be new skills that get adopted. But in the meantime, the services back them up. They complement what they do and what they have. And in some cases, in some markets, you actually can't even hire nurse navigating care managers. They're either not available or they might be cost prohibitive. And so what we do is we provide a more scalable solution.
It's in the one-stop shop. I like the sound of that. I've been with Chuck Saunders. He's the CEO of newly unveiled Integra Connect, which is a new big play in the specialty care value-based payment space. Chuck, thanks for your time and good luck.
Thanks, Matt.